Again, welcome to the teaching session of Department of Urology, Savai Man Singh Medical College, Jaipur. So today we have a teaching session on evaluation of hematuria, and this would be presented by our resident, Dr. Gajnendra Nagar, and this would be moderated by our faculty, Dr. Somendra Bansal. Today we have an expert faculty with us, Dr. Ankur Mittal. Dr. Ankur, thanks for joining our session today. So I'll just briefly introduce you. Dr. Ankur is Associate Professor and Head, Department of Urology at AIIMS, Rishikesh. He is also the Program Director in Female Pelvic Medicine and Reconstruction. He has multiple awards, including AUA, USI, Travel Award, Best Teacher Award, Young Urologist Award. His basic interest is in uro-oncology, female pelvic medicine, and robotics. So welcome once again, Dr. Ankur.
Thank you, sir.
In the meantime, I would request our moderator, Dr. Somendra, to just invite the presenter and start the class, please.
Yes, sir. Thank you, sir. Good morning, everyone. In continuation of our department academic program, today's seminar on the evolution of the hematuria and its management, and which will be presented by Dr. Gajnendra Nagar. Now I invite Dr. Gajnendra Nagar to start his presentation. Dr. Gajnendra,
Okay.
please share.
Yes, sir. Yeah, I am unable to share, sir.
I will just, Mr. Nimesh, just allow Dr. Gajendra to share, please.
Sir, he can share, sir.
Gajendra, go ahead. You will be able to share.
He is showing that advanced sharing options includes the who can share only host all participants.
Mr. Nimesh, can you help him?
अभी शिवम सर ने अपना शेयर किया ना, like you also you can share. शिवम सर
एक बार देखिए, आपका कुछ गड़बड़ है. Do you have anybody with you? नहीं. So आप फिर से कर जाओ.
Yes, sir.
उसमें options होते हैं, देखो.
You are also co-host, sir. Gajendra sir, you can share.
Co-host, you will be able to share. So in the meantime, when
yes, sir, इसमें ये show कर रहा है कि who can share advanced sharing options, who can share. First is only host, second is only all participants.
निमेश जी, एक बार फिर से आप देखिए, मैं इसमें और just send me on email. You have sent me on email, right?
Yes, sir.
एक बार और कोशिश कर लीजिए, नहीं तो मैं अपनी तरफ से शेयर करूंगा, है ना? Let's see. 1 minute. Just hold on. Hold on. There may be some problem here.
Yes, sir. Okay, sir.
Yeah. Go ahead. Go ahead. Full screen, please.
Hello.
Go ahead, Gajendra.
Yes, sir. Good morning, sir. My topic is and the management, and my moderator is Dr. Somendra Bansal, sir. First of all, introduction. Hematuria is a sign of the medical illness in the antiquity. Hematuria is defined as the presence of the RBC in the urine. It is one of the most common indications for the urological evaluation. Differential diagnosis of the red urine can be some medications like the phenolphthalein, phenothiazines, rifampicin, nitrofurantoin, ibuprofen, chloroquine, doxorubicin, and it can be due to some dye foods like the beetroots and the blackberries, and it can be due to the chronic lead mercury poisoning, and with it can be due to some metabolites like the bile pigments, melanin, methemoglobin, porphyrin, tyrosinosis uretase. Classification of the hematuria. According to the visibility, hematuria can be gross, that can be seen with the naked eye, or it can be microscopic. If 3 or more than 3 RBC per high power field on the properly collected centrifuge urinary specimen, and microscopic hematuria can be symptomatic or it can be asymptomatic. According to the timing, it can be initial, terminal, or total. If the source of the bleeding, in initial hematuria, source of the bleeding is from the urethra, and in the terminal hematuria, the hematuria occurs at the end of the maturation, and the source of the bleeding is the bladder trigone, bladder neck, and the prostate, and in a total hematuria, source of the bleeding is bladder and the above. According to the cause, hematuria can be medical or the nephrological cause, and which can be glomerular and the non-glomerular, and it can be surgical or the urological. Causes of the transient hematuria are the rigorous exercise, fever, sexual intercourse, menstrual contamination, and the infections. Glomerular hematuria. Glomerular hematuria is suggested by the presence of the dysmorphic RBCs, RBC cast, proteinuria, and brown or cola-colored urine. Renal biopsy is the confirmatory for the diagnosis, and laboratory investigations that are needed: serum creatinine, creatinine clearance, urine protein, or 24-hour urinary exclamation. Most common cause of the glomerular hematuria is the IgA nephropathy, which is the Buerger's nephropathy, and it accounts for approximately 30% cases. And other causes are the mesengoproliferative glomerulonephritis, focal segmental glomerulonephritis, familial nephritis, membranous glomerulonephritis, mesengocapillary, focal segmental sclerosis, SLE, and post-infectious glomerulonephritis, and with less cases, subacute bacterial endocarditis. IgA nephropathy or the Buerger's disease. It is the most commonly occurs in the children and the young adults with a male predominance. Clinical presentation is usually hematuria after acute upper respiratory tract infection or after exercise. Hematuria may be associated with the low-grade fever or the rashes, and it can be asymptomatic. Prognosis is the good indicator of the poor prognosis are the initial abnormal RFT, older age at the onset, consistent proteinuria, and the presence of the hypertension. Renal biopsy is the confirmatory. It reveals the deposit of the IgA, IgG, or beta-1c globulin. There is no effective treatment for this condition. Renal function remains stable in the most of the patients, and no other non-long-term complications. Glomerular hematuria. In the glomerular hematuria, in urine examination, there will be a circular RBCs, no RBC cast, and the proteinuria. Causes are the tubulointerstitial nephritis. Vascular causes are the renal artery thrombosis, embolism, AV fistula, and the renal vein thrombosis. And another cause is the nutcracker syndrome. Microscopic hematuria. It is sign rather than the symptom. According to the AUA, 3 or more RBC per high power field is required in the centrifuge urinary specimen. Prevalence in the normal screening population is the 6.5%, and the rate of the malignancy in the patient with a single positive urinalysis is 3.6%, and the risk of the malignancy diagnosed is greater in the patient with the higher degree of the hematuria, male gender, and the risk factor for the malignancy. Single positive urinalysis should promote the full evaluation. Differential cause of the acute asymptomatic microhematuria includes the neoplasm of the kidney, ureter, bladder, prostate, or the urethra, and it can be due to the infection and the inflammation like the cystitis, pyelonephritis, urethritis, tuberculosis, and the schistosomiasis when the history of the travel to the endemic areas, and the hemorrhagic cystitis. Stone of the kidney, ureter, and the bladder, benign prostatic enlargement, medical renal disease, congenital or the acquired anatomical abnormalities, which include the polycystic kidney disease, uretropelvic junction obstruction, ureteral stricture, diverticulum, and the fistula. Other causes are the exercise-induced hematuria. Exercise-induced hematuria, endometriosis, hematological disorders, papillary necrosis, AV malformation, renal vein thrombosis, interstitial cystitis, trauma and the recent genitourinary tract surgeries and the instrumentation. Common risk factor for the upper urinary tract malignancy in the patient with the microscopic hematuria are the male gender, age more than 35 years, history of the smoking, history of occupational exposure to the chemical or the dyes, analgesic abuse, history of gross hematuria, history of the urological disorder or the disease, history of irritative voiding symptoms and pelvic irritation, history of chronic urinary tract infection and chronic indwelling foreign bodies, and exposure to the non-carcinogenic agents or the chemotherapy agents such as the alkalizing agent. Requirement for the microscopic evaluation. Urine dipstick test is generally not sufficient and it should be confirmed with the microscopy on single positive, according to the AUA, single positive microscopy is sufficient, and false positive microscopy analysis can be due to the first void after the prolonged recumbency or after the rigorous exercise or sexual activity. False negative can be due to the very diluted urine, especially when the osmolarity is less than 308. Selecting patient for evaluation of the hematuria. Benign cause should be excluded, especially in the woman, and re-evaluation should be done. Urinary tract infection should be treated, and the microscopy, urine microscopy should be repeated to look for the persistent hematuria. Exercise abstinence from the exercise will be needed. A patient on the anticoagulant and the antiplatelets should be evaluated in the same way as the other patients. History taking. History should be include the drug history, medical history, history of the previous urological surgery and the febrile UTI, family history, and the history of the smoking. And goal should be to rule out the infections, menses, recent exercise, medical renal disease, recent instrumentation, retained foreign bodies, and the trauma, because they would warrant variation from the standard evaluation. Thorough physical examination should be done, and it should be focused on the GU system. Examples are the flank tenderness, masses in the flanks, abdomen, or the suprapubic area, and large nodular tender or the fluctuant prostate. And there may be various signs of the coagulopathy like the bruising, infections, and the renal disease like the hypertension and the edema. Urine flow rates and the post-void residual urine is estimation in the suspected case of the urethral stricture and the BPH. Laboratory investigations needed are the urine analysis, urine culture, renal function test, and serum-based PSA, and nephrological cause of the hematuria should be ruled out. Dipstick for the blood in the urine. It is a screening method. It utilizes the peroxidase-like activity of the hemoglobin to generate a color change. The degree of the color change is directly related to the amount of the hemoglobin. Sensitivity is the higher with the low specificity, and it can be false positive in the myoglobinuria or the hemoglobinuria. Contamination of the specimen with the menstrual blood, dehydration, and the exercise. And myoglobin and hemoglobin can be confirmed by the absence of the RBC on the microscopic examination. Urine microscopy. High power magnification or the phase contrast microscopy used to help in the determine the source of the bleeding. Upper tract imaging. Multi-phase CT scan is the investigation for the evaluation of the asymptomatic microhematuria. Offer complete imaging of the urinary tract and the highest sensitivity and the specificity. If CT is contraindicated, like the GFR less than 30, then MR urogram can be advised. If the both contrast and the MRI possess the risk, then the NCCT in conjugation with the RGP to evaluate the calyces, pelvis, and the ureter is appropriate. Cystoscopy is the key component and reliable way to examine the bladder and the urethra. It should be performed in the all patient above the 35 year of the age and having risk factor for the malignancy. It can be omitted in the person less than the 35 year of the age without risk factor. Blue light cystoscopy is not a routine part of the evaluation of the microhematuria. AUA recommend against the blue light cystoscopy due to the increased rate of the negative biopsies and the adverse reactions. Urine cytology and the urine biomarkers. Urine cytology is not an initial part of the evaluation for the microscopic hematuria. It has a good sensitivity and the specificity for the high-grade urothelial carcinoma, and sensitivity is decreased with the lower grade of the urothelial carcinoma. FDA-approved biomarkers are the NMB22, BTA, FISH, immunocytology, and 4CA and the mucoglycoproteins. And these biomarkers are currently non-recommended due to the insufficient current evidence. Cytology is indicated in the high suspicion of the urothelial carcinoma if initial workup is negative and in patient with the symptomatic microscopic hematuria. Follow-up of the negative initial workup. There are the three AUA guideline statements. First, 1 and 2 statements is about the annual urine analysis for the 2 year. If the second analysis is negative, then patient should be released from the urological care. And the third is the repeat hematuria evaluation within 3 to 5 years in case of the persistent asymptomatic microhematuria or for the development of the symptom or for gross hematuria. Patient having recurrent persistent evaluation with the incomplete evaluation should be completed their full evaluation. This is the AUA microhematuria risk stratification classification published in the Journal of Urology in June 2020 by the AUA. And patient can be divided into the 3 groups: low, intermediate, and the high groups. A low risk group should include meet all the criteria, which is the woman is less than 50 years, man is less than 40 years, and never smoker or less than 10 pack per year. On urine analysis, there will be 3 to 10 RBC per high power field, and there is no other risk factor for the urothelial cancer. In the intermediate risk, patient as is woman, if the woman is between the 50 to 59 year, man is between the 40 to 59 year, and the patient is taking 10 to 30 packs per year of smoking, and on urine examination there is a 11 to 25 RBC per high power field, or the patient with the low risk patient with additional risk factor for urothelial cancer in repeat urine analysis. And the high risk group is more than 60 years, both for women and men, and more than 30 packs per year. And on urine examination, there will be a more than 25 RBC per high power field and history of gross hematuria. This is the microhematuria evaluation algorithm. Patient with microscopic microhematuria should be evaluated thoroughly with history and the physical examination. Non-gynecological and the non-malignant cause. Gynecological and non-malignant cause should be ruled out. After this, the patient is stratified into the 3 groups. First is low, intermediate, and the high risk according to the AUA stratification, risk stratification classification. If the patient is fitted in the low risk group, then there will be a shared decision making between the clinician and the patient about the repeat urine analysis within 6 months or cystoscopy and ultrasound. If the patient fitted in the intermediate group, then the cystoscopy and the renal ultrasound is used as a upper tract imaging. And in high risk group, cystoscopy and CT urogram is needed. If this evaluation is this evaluation it is negative, then repeat urine analysis should be done within 12 months. If it is also negative, then the patient should be released from urological care. If the full evaluation is done and repeat urine analysis is positive, then there will be a shared decision making regarding the repeat evaluation and the observation. And if the cross-sectional imaging should be considered if it is not performed previously. And if a patient is found with the non-malignant or the gynecological source of hematuria, then this should be treated and the repeat analysis should be done. If it is negative, then it is released from the care. Symptomatic microhematuria. Symptomatic microhematuria is the risk of the malignancy is slightly higher than the asymptomatic. It is 10%, and the symptom may identified as a benign cause. Cystoscopy recommends regardless of the age. Cytology is an option in the patient with irritative voiding symptoms, and cystoscopy should not be vomited even if the cytology is negative. Gross hematuria. Causes are same like the asymptomatic microhematuria. There will be increased likelihood of the finding clinically significant lesion, and 20 to 25% patient with gross hematuria have GU malignancy. And according to the AUS, cytology, cystoscopy, and the CT urogram can be done. Assess the hemodynamic instability of the patient, CBC coagulation parameters. If there is a negative initial workup, then gross hematuria evaluation should be follow as asymptomatic microhematuria. Hemorrhagic cystitis. It is an intractable hematuria localized to the bladder. It often found in the elderly patient with the comorbidities, and it can be transient or the life-threatening. It is characterized by the diffuse inflammation and bleeding from the bladder mucosa. Differential diagnosis of the for the hemorrhagic cystitis can be infectious like the bacterial, viral, which includes the BK virus and the adenovirus, fungal and the parasitic. Trauma to the external trauma or the post-surgical trauma to the bladder, malignancy like the bladder and the bladder invasion from the local or the distance primary, vascular malformation, malformation, chemical exposure to the cyclophosphamide, phosphamide, busulfan, thiotepa, and the aniline dye and the ether and the non-oxynol 19. History of radiation therapy, medication induced, which can be penicillin and the derivatives, and other medications are the bleomycin, danazole, allopurinol, acetic acid. And it can be due to the manifestation of the systemic disease like the amyloidosis, rheumatoid arthritis, and the Crohn's disease. Management of the hemorrhagic cystitis. After diagnosis of the hemorrhagic cystitis, initial management is to increase the output, urine output with the proper hydration and the diuresis, and with the Foley's catheterization and continuous blood irrigation. If it fails, then the cystoscopy with the clot evacuation plus minus fulguration should be done. If there is a biopsy should be taken if there is a concern of the malignancy, and other supportive care should be done with, like the blood transfusion. If the initial supportive management is failed, then we can use an intravesical agent like the LM. If the hematuria is continue after the 48-hour, hyperbaric oxygen therapy can be done, and supportive measures should be continued. And if along with bilateral nephrostomy tube for diversion of the urine, if hematuria continue, with bilateral nephro-occlusive tube. If the despite hyperbaric oxygen therapy hematuria continue, then we can use intravesical formalin 1%. Before the initiation, before the treatment with formalin, pre-treatment cystogram is needed, because there is a risk of the bladder fibrosis, reduced bladder capacity, and if the hematuria is continued despite this, then the 4% formalin should be used. If options for the internal if hematuria is continue, then cystoscopy with the conduit urinary diversion should be done. Intravesical agents used in the hemorrhagic cystitis are the alum, which is the first line intravesical therapy. 50 gram of alum is used in the in a 5-liter bag of the sterile water should be used, and the rate of the irrigation is 200 to 300 ml per hour. Mechanism of action of the alum is the protein precipitation on the urothelial lining which stimulate the vasoconstriction and the decrease in the capillary permeability. Success rate is 45 to 100%. There may be a risk of the systemic absorption, which leads to aluminum toxicity in the patient, especially with renal insufficiency. Alternative agent used for the initial intravesical installation can be a prostaglandins and intravesical sodium hyaluronate, silver nitrate. In patient with the when the silver nitrate is used as a intravesical agent, pre-treatment cystogram is needed to rule out the reflux because there is a risk of the precipitation and upper tract obstruction. And the solution used is the 0.5 to 1%, and it should be installed for 10 to 20 minutes. And it results in the chemical coagulation at the bleeding sites. Another agent is the aminocaproic acid. It is a competitive inhibitor of the activator of plasminogen, including urokinase and the
Gajnendra,
Yes, sir.
we can skip this. How many more slides you have? Yeah, but we can just, because we are basically dealing on hyper evaluation of hematuria, we can skip this, yes, right?
Yes, sir.
So how many more slides you have? So go to the maybe summary of the whole thing,
Yes, sir.
and
Yes,
then
sir.
we will discuss it.
Okay, sir.
Yeah. Summary, go take home message. Go back. Yes, go ahead.
Take home message is the hematuria can be gross or the microscopic. Significant hematuria is the 3 or more than 3 RBC per high power filled on the urine microscopy. Evaluation with the hematuria begins with the complete thorough history and the physical examination. Urine test, laboratory test with the cystoscopy and the imaging, preferably CT urogram is needed. Urine dipstick test is the screening test only. Urine microscopy is confirmatory. Urine cytology and biomarker are not indicated in the initial evaluation of the asymptomatic microscopic hematuria. Rule out reversible cause of the hematuria like the benign urological cause, UTI, and the gynecological cause. And the retest with urinalysis. If the persistent disease, then the complete evaluation includes the cystoscopy, upper tract imaging, preferably CT urogram should be done. If previously incomplete evaluation. In absence of the nephrological cause and the benign urological cause and the presence of the gross hematuria, it needs full evaluation with the upper tract imaging and the cystoscopy. Nephrology reference is needed if there is a reduced RFT and the protein. Thank you, sir.
Thank you, Gajendra. Somendra, go ahead.
Yes, sir. Thank you, Gajendra, for nice presentation. Now I invite Dr. Ankur Mittal, who is Professor, Department of Urology, MCC case. Dr. Ankur is also my batchmate. We have done MS from R&T Medical College in the same batch. Sir, due to some technical error, my video is not working. So, Dr. Ankur, please give your expert comment.
Thank you, Dr. Somendra. And, it is a pleasure, again, I will say, and it is really a thank to the Department of Urology, SMS, and Dr. Shivam, sir, to involve us, actually, and it's a pleasure to be part of academics. So I think it's a very good presentation, Gajendra. The very important topic which we are discussing today is hematuria. So it seems to be a small word, but it is a world, actually, for a urologist. So once, I think you have covered almost everything in the theoretical part. I would like to say whenever a urology resident is seeing a case of hematuria, I think there should be a flow chart in his mind how to evaluate one by one, because anytime if you skip anything, you can miss a lot of things. Most of the time, what we are biased as a urologist are that we only try to see only those causes which are in our mind, mainly most common usual causes of urological hematuria. But it is not the true, it's not truth. So I think, as you rightly said, I want to reinforce some facts that once you have seen a case of hematuria, first really think whether it is hematuria or not. Every color urine is not hematuria, as you rightly said. Once you are sure that it is a hematuria, you grossly divide into gross and, microscopic. And to make it very simple, actually, you have shown us different guidelines of asymptomatic microscopic hematuria management, low risk, intermediate risk, high risk. And you've also discussed about gross hematuria. So I think the evaluation part is almost same for gross hematuria as well as asymptomatic microscopic hematuria, except the low risk category. So if you just see the low risk category, where you classify your low risk asymptomatic microscopic hematuria based on your age, less than 35 or less than 50, your number of smoking years and other risk factors. AUA says in that it is optional. It should be a shared decision making, that whether you want to go for a cytology or you want to go for a cystoscopy or you want to go for imaging. But if you are treating like intermediate and high, the management and evaluation is almost same as gross hematuria. So we should not be confused seeing these flow charts that the management will differ. It doesn't differ. And what I want to add here is that these guidelines basically, are from Western world. But I think Dr. Shivam sir will agree to us that what we see here in Indian scenario, even in young population, the things are not unusual. We are seeing now plenty of cases, carcinoma of urinary bladder in young patients. So it's not that less than 40 years is quite unusual to have a carcinoma of urinary bladder as of now. It is quite common now in Indian population. So what I feel that we should, again, this low risk group should be dealt carefully before skipping cystoscopy or before skipping imaging. In this low risk group of asymptomatic microscopic hematuria, we should really think of, and I think keep our threshold low to do a cysto at least. Cysto is an office procedure, as ultrasound is a part of clinical examination. Now cysto is also a part of clinical examination. So just doing your office cysto will help you a lot. And that cystoscopy should be really, whenever we do it, I think it is important to really do it in a very systematic way. It should be a mapping. There should be a very good mapping for a cysto. Once you go inside for a hematuria case, it should be really done in a stepwise manner, and always document each and every finding in your sheet, because the person who does a cysto is important, but the person who is reviewing the case probably should also have the same information like as he has seen. So upper tract evaluation on a cysto is very important, which sometimes we miss. So whenever you do, so whatever reflux is coming, you have patience, and we should always focus on what is coming from bilateral orifices. Sometimes we miss things which are coming from the upper tract, and we just focus on the lower tract. Because whenever we see hematuria, don't forget the upper tract. The upper tract is also a cause of hematuria. And I want to say, you said, that hematuria, painless, painful, we can, on clinical history, definitely we can, differentiate between what are the causes of painless. And I would like to say that even it is painless, we should not just keep away the malignant causes away. There are certain malignant causes which can also, present as a painful hematuria. So what can be then? So see, just imagine if there is a case of UTUC, right? And the patient is having a bleeding. So although you have upper tract malignancy, but they sometimes this patient behave like a clot colic, and they have a significant pain, and they present like a flank pain and hematuria with definitely vermiform clots, and you have suggested. So just don't make don't keep a statement that, okay, if it is painless, it is malignant, if it is painful, it is infective. It's not like that. Similarly, again, I want to say that you have discussed upon cytology. Cytology we all use very often. So as the guideline says that if it is initial evaluation is not negative, I think it is not indicated in initial go right now. But I think we have seen, whenever, even if it is not a gross hematuria, and if you have time, it is elective surgery, there is no harm in doing a cytology also to add in a preoperative workup. The cytology, although the guideline says that it is not indicated, the initial workup is positive. But see, just I am giving you two conditions. Like you have done a cytology of a patient, it is positive. Now you have done a workup, but in workup, you are not getting anything out of that. Your imaging is negative. Now you're doing a cysto, your cysto is negative. Okay, now this just a positive cytology. If your cysto is negative and your imaging is negative, will definitely give you something in your head that, okay, we are missing something. So it can be upper tract again. The small lesions of upper tract urothelial carcinoma are sometimes missed on imaging too. The CT urogram probably can miss it. So in that case of time, if you have a repeated cytology positive, if it is done pre-evaluation, will definitely lead to do a upper tract imaging by a flexible scope or whatever. and you can get a diagnosis sometimes. Again, I'm giving you a scenario like, just you say you have a cytology positive, and another scenario, you have a cysto is positive and there is a bladder mass and you did a TURBT. After TURBT, the biopsy report come out to low grade urethral carcinoma, or say it is Panlab. So, but if you have done a cytology prior, cytology positive means is indicative of high grade disease, but on your biopsy, you are getting a low grade disease of Panlab. So again, we need to scratch our head that, okay, we should not rely on the biopsy report. We should not leave it. Again, we should evaluate our upper tract or get the biopsy reviewed. Either the biopsy review will tell you high grade disease, or you are missing some high grade lesions in the upper tract. So sometimes this doing just a simple test, if feasible, it helps us. So I think whatever guidelines we are suggesting, guidelines are to guide us. But in Indian scenario, we should always add our practical experience, and things which are feasible should not be missed if it can. Sometimes these are game changers. So the one point just I want to more add, evaluation, like whenever we evaluate a case of hematuria for imaging, as you rightly said, I think we should understand the difference between a triphasic, triple phasic CT abdomen pelvis and a difference between a CT urogram. So again, using these two words of imaging, sometimes we write triple phase CT abdomen pelvis just as a requisition, and radiologists will follow what you are writing. But if you write a CT urogram, they will follow what you are writing. So there's a gross difference. When you are talking about a hematuria, see, it can be upper tract, it can be lower tract, it can be small lesions, which we have discussed, which can be missed. Always good to have a CT urogram, or you need to add a delayed phase imaging in CT abdomen pelvis, specifically mentioned separately, because if you don't mention the delayed phase, probably you will not get the delayed phase in that CT and you may miss your cause of hematuria. And CT urogram definitely is a good investigation for that. So I think an important point else which I just want to add on is, see, in young age population, see, whatever we are discussing about hematuria, we are usually seeing cases of more than 50 years or more than 40 years. They are not usually young. But we should also keep in mind there is a subgroup of population of young age where there are plenty of causes of hematuria which we can miss. Like in young age population, we get a case of cystitis cystica. These patients are common in young age only, and they present to you hematuria. So I think again a cysto, even if it's low risk, is important, because if you do a cysto only, you can diagnose these patients to have those submucosal cystic lesions all over the bladder, and presenting the case of cystitis cystica when you really need to go ahead with a biopsy and to rule out with the cystitis cystica glandularis, and to rule out an intravesical obstruction and infection, a part of cause of it. So the young population less than, which is coming in low risk, again, I'm emphasizing low risk population should not be missed, because the guidelines says optional imaging, optional cysto, optional cytology, but this is a group where we miss the cases. And I think at the last, just I want to add one more point about the hyperbaric oxygen. You have rightly, actually you were talking about radiation cystitis and hemorrhagic cystitis, in which a cause is radiation cystitis. See, this is I think a nightmare for any urologist. Whenever we deal a case of radiation cystitis, you can start with anything and you can end up with anything with even no results. You have said you need to ligate the bilateral ureters, and you need to do bilateral PCNs. Sometimes you end up with cystectomies, right? I think availability of hyperbaric oxygen is a concern right now. Probably it is not available in India freely. In our practice, fortunately, we are having hyperbaric oxygen in our center. So earlier we were not exposed to it, but what I just want to share the experience that hyperbaric, we have a recent review article on hyperbaric oxygen 2018 in BJUI. I would advise all the reasons to just go through that. It's a wonderful review article on hyperbaric oxygen. We have recently started giving hyperbaric oxygen over and above the other modalities which we were using earlier, like LM and all those things, So if it is not responding after 48 hours, as you said, we directly, start on hyperbaric oxygen. And we have seen that it works like a wonder. So see, if you understand a pathophysiology, radiation and arthritis, ischemia, necrosis, sloughing, hematuria. This is the pathophysiology of your, radiation cystitis. Hyperbaric oxygen, it increases the tissue hyperperfusion, and definitely it helps. So 15 to 30 sessions are usually given. I just want to leave a school of thought about hyperbaric oxygen that, okay, it's not only in guidelines, but it works also. But again, the availability is a concern and can be used on other tricky methods like tranexamic acid and LM and all, which are usually, again, tricky to use. So I think with these words, I just want to, ask Shivam sir to carry forward the session. Thank you so much, sir.
Thank you. Thank you, Ankur. Somendra, would you like to make any comment? Then I will go ahead. Yeah.
No, sir, Ankur has already discussed all the aspect of the hematuria.
Right.
Yes, sir.
So, Ankur, it was wonderful. I think you summarized the whole thing very well and whatever he had missed. So, you began with saying that it is a small word, but it contains the whole world. That was a beautiful comment that you made. And then you said that the residents should have in their mind a flow chart whenever they see a patient with hematuria or any symptom. So that's a very good comment that you made, that you have to have something in your mind. How would you proceed in a particular symptom? And then you said about the cystoscopy, which should not be a hurried cystoscopy. It should be done patiently, mapping all the areas, even seeing the ureteric orifices, waiting for maybe 1 to 2 minutes and just trying to see whether there is any efflux of blood through them or not. Wonderful. Secondly, then you said about the importance of urine cytology, which is often missed in the guidelines, and as a kind of a routine workup in these patients probably may help us a lot. Similarly, an ultrasound of the abdomen, KUB region might help in a routine workup also. Similarly, you said about the CT. Yeah, whenever you advise an investigation, it's very important for the residents that you ask what exactly you want with the radiologist. Like I said, in a patient of hematuria, you require a focused CT urogram, where you also need a delayed image. So it's very important, because it's just not an imaging, but what exactly you want from that imaging is again very important. Then he stressed on these guidelines on low risk and all that, and you can miss sometimes even in young patients sinister disease. That is again very important. You cannot take these patients who are low risk also very lightly. And then lastly, he had made a comment on hyperbaric oxygen. Thank you very much for making that comment, because we were also discussing in our classes about hyperbaric oxygen. Last time we had a patient of radiation cystitis, and then ultimately we had to put bilateral nephrostomies, and luckily the patient had improved. But yes, hyperbaric oxygen is one of the very good method of treating these patients. And we were searching in our city also, and someone said that we had some center of hyperbaric oxygen. And I would also, maybe sometime later, I would request you to know exactly how much does it cost, and how can we also get this hyperbaric oxygen. So thank you, Ankur. And anybody has any faculty resident has any query to make, please go ahead. We have Dr. Anil Jain with us. There are many other senior urologists with us, as I can see. If you have any comment to make on what we have missed, please go ahead.
Good morning, Shivam.
Yes, Dr. Anil Jain, you're most welcome, sir.
Yeah, I enjoyed the classes conducted by you, and this is really keeping me in touch with academics. As Dr. Ankur and you people have already said, that a very systematic approach is very, very important. And I also like the comment that you should not think that painless means only malignancy and painful means only infective. So these are few things which are very, very important. Meaning by that we should not be rigid in our thinking, particularly for a subject like hematuria. And of course, malignancies have to be ruled out, but then the benign conditions like cystitis, cystica, and glandularis, all these have to be kept in mind, particularly in young individuals. So thank you very much for asking my comment. Thank you so much.
Thank you, Dr. Anil. If anybody else has to make any comment, otherwise we will conclude. So what I would like to say, the residents, whenever this patients of hematuria comes, be very careful. As Dr. Ankur has said, make a flow chart in your mind. Like suppose that this may not be hematuria also. So this may be just a colored urine. It may be factitious hematuria. You know, even a 1 drop of blood in 1 liter of urine can color it as hemorrhagic. So even so, if somebody comes in the OT and wants something, wants some leave, and he would just factitiously present himself as hematuria. So that again is very important. Women with in menstrual period or after the delivery, they can have hematuria, which can be present as hematuria. Again, about the glomerular hematuria, I think this is very important, particularly in young and children. You need to differentiate it. Besides the dysmorphic RBCs, there are a few other ways to diagnose it. As you said about the proteinuria, yes, more than 500 if you get albumin, or there are acanthocytes. Sometimes you may not get dysmorphic RBCs. So if you have acanthocytes, which are like vesicle-like protrusions from RBCs, if more than 5%, it shows that probably it is glomerular hematuria. Similarly, if the mean corpuscular volume is less than 75, it gives suggests that it could probably be a glomerular hematuria. So as a resident, I think we should know all these things, how to differentiate between glomerular and non-glomerular causes, particularly in children and young adults. Again, in these, about almost 80% of cases of asymptomatic microscopic hematuria could be idiopathic constitutional hematuria. So again, this group is again very important. How to counsel these patients again is very important, and so that they do not panic with hematuria. And again, I think Dr. Ankur has summed up very well, and I will thank Ankur and Dr. Somendra. Please give vote of thanks, and we will wrap up the session.
Thank you, Dr. Ankur, for excellent discussion and sharing your valuable knowledge. And thank you all other faculty members who attend this class. And thank you, residents. Thank you, sir.
Thank you, Ankur, once again. Thank you.
Thank you, sir. I would like to thank all the faculty members of Department Urology SMS, Dr. Somendra and Dr. Shivam Pidashi, sir. It's a wonderful initiative which is going, we are seeing from several months. And I am sure that definitely it will help the residents of SMS, definitely faculty members, and even the urologists all over. We have learned a lot from this session. It's not like that, the session has taught us a lot. Gajnendra has presented very well. So I think learning for everyone. Good exercise, sir. Thank you so much.
Thank you. Thank you, Dr. Ankul. Thank you, all the faculty members, residents, and all senior urologists who have joined us today in our session. So have a good day.